A very good evening and a very warm welcome to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction at our platform, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned ophthalmologist, Dr. Quresh B. Maskati, sir. Sir is MBBS, MS, DOMS, FCPS, FICS, consultant ophthalmologist at Maskati Eye Clinic, Mumbai. With such wonderful insights, we are going to talk about the topic for today, which is myopia control approaches to curb the global epidemic. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you, please proceed.
Thank you, Batul. And today we have a very interesting topic with us, that is myopia control and efforts to curb the global pandemic. This really has shot up in the last few years, and especially after COVID. All eye surgeons, all eye care professionals, even optometrists, opticians, people going to optical outlets, all of them have reported a surge in myopia, not only in children, but also in adults. This trend started some time ago, but let me just. Yeah. So myopia, there were traditional types. We were taught when we were students that there are two types. One is school myopia, which commences around the time that the child goes to school between 5 and 15 years of age. It increases by about half number, one number every year, and it stabilizes by the age of 15 to 18 years. And since we didn't know what caused it when parents asked us, but why is my child's number increasing? We would simply use the magic medical word called idiopathic. Idiopathic means we are idiots, we don't really know. And there was another type called pathological myopia or high myopia, which was associated with all the complications. So child was born with -10, -15 myopia. These myopias did not progress, but their complications like cataract, glaucoma, retinal detachment and all kept on happening. So this was our knowledge of myopia. And the global prevalence data, which is from 10 years old data, which already shows that in India, almost 1/3 of youngsters are myopic, which is something we share with the developed countries like USA and Mexico. And as we go east of India, you look at Taiwan, South Korea, Singapore, the numbers are almost every youngster is myopic. So the trend from 2014 to 24 has just worsened. And everywhere for India from 35, we're approaching 40, 45% and so on. So why does myopia progress? There are several factors at play. One of them is environment or the lifestyle. That means our need to look at gadgets. Like from a young age, you see these children, all of them on gadgets instead of going outdoors. Our study hours, our school timings, number of hours of close work that we do is increasing. Number of hours of outdoor activity is reducing. Also, our food habits. We ate good home food when we were children, but now children are eating more of the junk food, the burgers and the pizzas, not sitting in proper positions. So all this does contribute to the myopia progressing. But if there is a single slide that I want you to understand fully and take home message is this slide, which is what is called myopic defocus and hyperopic defocus. I'll explain to you. What happens is when we have myopia means the eyeball is longer than normal. We normally correct it by putting a concave spectacle glass. Now, a concave spectacle glass bends the rays of light such that they focus on the retina. Center of the retina is the macula, and that is where the central rays all focus. You see the green round thing and the red round thing, all of them focusing on the center. But when you wear concave glasses, the glasses, the spectacles, bend the peripheral rays of light and they focus behind the retina. When they focus behind the retina, the brain feels that the eyeball is too small. Why is that red line behind the retina? So it says, let the eyeball grow a little bit so that we can catch all the rays of light. Now, when the eyeball grows, you become more myopic. Every 1 millimeter that the eyeball grows, which it is not supposed to, you get 3 myopia. So what is desirable is that we should have such spectacles or contact lenses which make all the rays of light coming from infinity focus inside the retina, what is called myopic defocus, the green line. That is desirable. But unfortunately, our normal spectacles focus only the center in the center, central rays exactly of the macula, and the peripheral rays behind the retina, which is called hyperopic defocus. This is the biggest cause for the myopia to progress. Therefore, optical correction, giving the child. So child has -3 number, we give -3 spectacles. Child sees 6 by 6. We feel we have done our job. Parents are very happy. Child can read the blackboard well. But that is only corrective. It is not preventive. It doesn't prevent the myopia from increasing. As you can see in the middle picture, corrected myope has got hyperopic defocus because the concave glasses, spectacles which are there, they'll act like two prisms and they bend the rays of light towards the base of the prism, which is behind the retina. So ideally, we should be correcting it like in the last picture, bottom picture, where all the rays of light focus in front of the retina. So peripheral hyperopic defocus serves as the culprit, and even in the absence of visual signals from the fovea, it can stimulate myopic progression. So what they did, they took monkeys and they scratched out their retina, the macula. In spite of that, when they put the concave glasses in front of the monkey's eyes, the myopia progressed. So even when the monkey had no vision, the myopia progressed. So why is myopia control important? Why are we talking about this topic today? Because an uncorrected refractive error leads to learning difficulties. If the child cannot read the blackboard well, their performance goes down. It affects the psychosocial development of the child. And the child becomes introvert, only interested in his books because it's close by, he can see that. And these children become withdrawn, show less interest in socializing and in interaction, though they may be brilliant children. So how do we reduce the prevalence of myopia? Though there are no studies as such from India, but it is found that overemphasis that we have in our schools on academic performance vis-a-vis structured outdoor activity is a big factor. So in our schools, we should encourage outdoor activity and less dependence on books and on the study. Study is important, but it's not the overall end point of a child's education. So there's a brilliant study by Rose et al., old study, 2008, 16 years ago, which said that for a 6-year-old child, what is considered as bad is near work more than 2.5 hours per day. So if a child reads or does near work on a computer, on a gadget, on a mobile phone for more than 2.5 hours a day, there is greater risk for development of myopia. So even if he doesn't have number, he will get a number if the amount of work, near work, is more than 2.5 hours a day. And if your outdoor activity is less than 1.5 hours a day. So greater amount of outdoor activity, exactly opposite, halts the myopia onset. So myopia which is going to come in will not come in if the child is spending more time outdoors, because they said that the natural light gets a higher amount of dopamine, and that is one of the reasons why it happens. The Chinese tried to increase the amount of lux or the amount of light indoors, but it did not work. The child requires sunlight. So we say that you must spend more than 2.5 hours outdoors. That is called high amount of time outdoors, which can halt myopia onset. So two take-home messages here. The less time that the child spends indoors on near work and the more time that the child spends outdoors, both of them reduce the prevalence and the progress of myopia. The third factor is if the child develops, because of genetic factors, if the child develops myopia early in life, the chances of it progressing faster is more. So if you see the slide, on top is written the number 7. So age of onset at 7 years, if the child gets myopia at the age of 7 years, he will increase by almost 1 diopter per day unless we take some steps. While if the child gets his first pair of glasses at the age of 16 years, the chances of it increasing it will increase by only 0.1 diopters per year. So the earlier the age of onset, the more is the chance of progression. This is what we know. Based on this, myself and my optometrist Chandrasekhar Chavan, we developed a myopia morbidity risk point system, which meant that if we gave points, minus points, if the child was wearing single vision glasses, as I told you, then -1. If both parents were myopic, the more risk, so -2. If the age of onset was early at the age of 6, we gave -3 points. And if there is less outdoor activities, we gave -1. If there is more use of more than 1 hour use of mobile phone per day, we gave -1, and so on. So we made a risk factor so that we could explain to parents that if you got just -3 points, your child is at low risk. If you got -6 points, then medium risk. But if your child scored more than -9 points, there is almost guaranteed that there will be irreversible visual damage by the age of 55 to 60, unless myopia control measures are adopted. So this helps me to explain to parents that how aggressive we have to be in controlling myopia. Again, I say mere giving glasses is not sufficient. So what are the risk factors? Just to summarize some of them again: age of onset, the earlier, the younger the patient, the more the risk. Refractive error. Suppose the child, all children at the age of 1 year to 3 years have a little bit of a plus number. But if the child has less plus refraction than expected for age, it is called pre-myopia. These children also will have a greater tendency to get myopia as they grow older. Family history of myopia, at least one myopic parent. East Asian, I told you, Vietnamese, Taiwan, Singapore, China, the more chances of myopia progressing. And I mentioned also time spent outdoors, less than 1.5 hours per day, and spent near work more than 2.5 hours per day. These are some of the risk factors. And these are some of the associated comorbidities. Why are we saying that? One parent asked me, what difference does it make if my child has low myopia or high myopia? It's a difference in the spectacle thickness. No. The higher the myopia, the more the risks of myopic macular degeneration, detachment, myopic retinopathy, glaucoma, cataract, and so on. So we are very keen not to let the myopia go beyond -5 or -6. So see the amount of risk difference. A myopia, if it's -7 to -9 myopia or beyond, what is the risk of maculopathy? 126 times that of somebody who doesn't have myopia. 126 times more likely. So just see the risk. This is a myopic maculopathy that you see. And what about retinal detachment, where you can lose vision? If you have -15 and above, you're almost 100 times more likely in your life to get retinal detachment as compared to somebody who doesn't have myopia at all. So this is a retinal detachment that you're seeing in the picture, where the lower part is seen clearly, and the upper part is seen like a gray glow, which is hiding the disc also, like a curtain over the eye. That's a retinal detachment. And risk of cataract, they can get what is called posterior subcapsular cataract. If you have -6 and above, 5.5 times more likely to develop a cataract early in life. So let us go straight. So now we've scared you enough. We know that single vision glasses are not the thing. So there are different modalities which have come up in the last few years on how to control myopia. One of the first which came out was executive bifocals. That means you had a minus number, and the lower half there was a plus number. So that the plus number reduced the hyperopic defocus. But that reduces it only a part of the retina, so it's no longer popular. Instead of that, you have what is called as multifocal contact lenses, where you have rings which give you near vision and distant vision in the same, so that the plus number in the contact lens, the central area, is corrected for myopia, for minus number for distance. But the peripheral, instead of minus number, it gets a plus number so that the rays of light focus inside. And there is something called orthokeratology. Orthokeratology is use of special contact lenses which are worn by the child at night. So when the child wears the contact lenses at night, it presses on the cornea, changes the shape of the cornea, and during the day, the child doesn't wear glasses or contact lenses. Now, this was used to prevent children from who didn't want to wear glasses in school, they were shy. But it was found by accident that this also prevents or slows down the myopia progression. So now orthokeratology is an accepted mode of treatment. And then there is topical atropine drops, which I will talk to you about, and peripheral defocus spectacles, which again work like the multifocal contact lenses. That means they have minus number and plus number in the same glasses. So the peripheral rays of light focus in front of the retina. We'll talk a little bit about these. So let's talk about orthokeratology. So this is the shape of the cornea, the first picture prior to orthokeratology. It's dome shaped. And when you put the contact lens on overnight, the cornea flattens down. As you can see in the second picture, the cornea is flattened down. So the number changes and it becomes near zero. This is what the contact lens looks like. This is how it looks like when you put it in the eye and you put a drop of fluorescein. This is how you get alternate rings of pressing on the cornea and the flat curvatures and steep curvatures. It's called reverse geometry lenses. We won't go into technical details, but these are special lenses meant for nighttime wear, meant for children. And they do a pretty good job. However, many people have this aversion that my child is too young to wear contact lenses. And there is always the danger of infection if you don't clean the lenses well. Though the chances worldwide are very, very low of infection, but this is a good treatment modality. The second thing we need to know is lifestyle change, which all of us can implement in every myope, whether you're an eye care practitioner or a family physician. Minimum prescribed 2.5 hours of outdoor time, no use of mobile except for school work. And if they have to use, then an iPad is better, laptop is better, desktop is better. The bigger the screen, the better it is rather than on the mobile. And healthy eating habits. So play outdoors and eat healthy foods and less of junk foods. So this is the difference in, I told you the third one was myopia control lenses. These are special spectacles, which I told you traditional glasses focus the central rays of light on the center and the periphery at the back called hyperopic defocus. In myopia control lenses, there are two technologies. I won't go again into details. One is called DIMS or DIMS technology, and one is called HALT or HALT technology. They are made by large firms like Essilor, Hoya, Zeiss. I have no financial interest. So they bend all the rays of light to focus inside the retina. So there is no hyperopic defocus. Light focuses on the retina in the center where it should. And in the periphery, it focuses slightly in front. So that's called a myopic defocus. So you get special glasses. They're a little expensive. The glasses cost about 15,000 rupees, but it's well worth the cost. So these are, so as I said, no financial interest, but these are some SLR lenses. These lenses provide correction via single vision zone. So center is for myopia, and there are highly aspherical lenslets. This is quite a bit of physics. So you can, but there are rings. There are 11 rings over there, and those bend the rays of light to focus in front of the retina. The child doesn't realize it. The child feels it is like a single vision glass itself, but it does tend to help. The other treatment modality is role of low-dose atropine for myopia control. It's available as 0.01%, and soon also it's going to be available as 0.05%. LDA stands for low-dose atropine. These are used as one drop at night, and they can be continued from the age of 5 years or 6 years to the age of 16 years. So we don't really know how it works. Some of the theories are that there is anti-muscarinic action, which helps in preventing axial elongation of the globe, anti-accommodation, etc. We won't go into the details. But once you start, it should be used for at least 2 years because the maximum effect appears in the second year. So if a child has got myopia which is progressing, only in children whom the myopia is progressing by more than 0.5 in 6 months, we should use these low dose atropine drops. It is perfectly safe. There are very few side effects, but it will slow it down. It may not stop it completely, but in the second year, it will work much better than in the first year. So which children should be offered this therapy? Kids over 5 years of age with a documented increase of at least half diopter in the past year or less, and after thorough discussion with their parents. So if in past year or past 6 months it has gone up by half a diopter, then you tell the parents that it is increasing. So let me see if I can stop it by giving you low dose atropine eye drops. Which children should not be given? Children with anisometropy. I mean, one has -3, one has -5. Don't give that. If the cylindrical number is more than 1.5, it doesn't work on cylinder. It works only on spherical number. Then syndromic children, children with cerebral palsy or birth defects or things like that, retinopathy of prematurity. So children who have something besides simple myopia, we don't give it. We don't know the long-term effects. And a child who has had pediatric cataract surgery, cataracts in childhood and operated, they get myopic shifts. It doesn't work in those children. So we do a baseline axial length to find out what is the length of the eye and what is the curvature of the cornea before we start the treatment. So what are the barriers to use of atropine? Some ophthalmologists are still waiting for long-term statistics, especially on the Indian population. But we have completed 5 years in India, and we found that the drops work very well. Almost 50 to 60% of the patients, it is able to slow down the myopia. And since the side effects are not there, I think it's great. It's just we need more ophthalmologists to listen to lectures like this and overcome their fears of this. And some parents are not convinced, especially in low myopes, when I tell them that its use may prevent the current 2 diopters becoming 3 diopters. It may increase only to 2.5. They said, Doc, it's too much of a hassle. My child doesn't allow it, because we spoil our children. One drop at night also, if the child creates a tantrum, the parents stop putting it. Many times I find parents coming to me after 3 months saying, Doc, I know you told me, but after the first free sample bottle you gave me, we stopped using the drops. So to summarize about low strength atropine, low dose atropine, it is 0.01%. It's perfectly safe for children above 5 years of age, must continue for at least 1 to 2 years. If the myopia is completely stable and doesn't increase at all, you can stop for a year and see if there is no rebound. You can keep it stopped, but otherwise you can restart again. And if 0.01% is not working, we can go for a little higher strength called 0.05%. And can be continued till myopia stops progressing, even up to 18 years. Though there are no studies in children above 16, but up to the age of 16, when they studied with children having taken it for 10 years in a row, there was no side effects. So you can continue up to the age of 18 years as well. So to summarize my talk, I have talked to you about first how important it is to control myopia, how we should not be just prescribing single vision glasses like -3 spherical and think we have done our job. We should educate parents on the need to put a brake on myopia progression, and that there are several ways to put a brake on myopia progression. One of them is orthokeratology, or use of special contact lenses to be worn at night, so that during the day the child wears no glasses or contact lenses. The second is low dose atropine, 0.01% or 0.05%, to be continued 1 drop at night in each eye up to the age of 15, 16, perhaps even 18 years. And if the myopia completely stops progressing, we can stop it and see whether it will progress. Then there is multifocal soft contact lenses. Little older children, you can try these. These work just like myopia control spectacles. And myopia control spectacles, I told you, were of 2 technologies, the DIMS technology and the HALT technology. And something which we can encourage all our children to do: spend minimum 2.5 hours outdoors in sunlight. Tell them, go out and play cricket, football, hockey, whatever it is, whether it's a boy or a girl, it doesn't matter. Avoid continuous close work. We must not be TV parents or mobile parents where the parents are busy, both of them are working. They put the child, they say, my child will not have dinner until the TV is on, or the child needs to watch videos on the mobile, otherwise he will throw a tantrum. So we need to educate parents that the fault is with you, not with the child. Right from early age, avoid the use of mobile phones or gadgets for near work, except for school work, if the school gives them work to do on a gadget. And that time, the bigger the gadget, the better it is. And we must emphasize something which we many times as medical persons, we feel it is not in our place to talk about food habits. No, healthy food with lots of green vegetables, milk. If they are non-vegetarian, then eggs, protein. These are all very healthy, and less of junk food, processed foods, the breads, the pizzas, the burgers. So these are all things which contribute to ill body and therefore ill eyes. So we need to emphasize some of these things which are in our control. Again, I'm addressing family physicians especially. At least we can talk to parents about diet, about avoidance of close work, and about spending maximum time outdoors. There's no substitute for sunlight. Bright light in the house is not a substitute for sunlight. We should remember this. So in conclusion, I thank you so much for your attention. The picture says, मैं तुम्हारा पैर पकड़ता हूँ, मेरा दिमाग मत खाओ. I hope I have not cowed your dimag, and I'll be happy to answer questions.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform with all our viewers and for making them understand about the topic in such a better manner. We have received few questions from the participants. So with all your due permission, I would like to put across those questions to you.
Yes.
So the first question is related to the effectiveness of myopia control method. So how effective are these myopia control methods, sir? If you can put some light on it.
The approximate percentage of for each method is about 50 to 60% effective. So I think it's a great percentage when the downside is very little. And in my practice, I combine low dose atropine with special spectacles. So when you combine two methods of myopia control, the success chances of preventing the progression goes up to almost 80%. Thank you.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question, and the other question is related to the side effects or risk associated with myopia control treatment. So are there any side effects, sir, if you can have some light on that?
So, of course, on contact lenses, if you follow the instructions of the eye care practitioner about proper hygiene, washing your hands, cleaning the lenses, using the solutions as we prescribe, putting it in the case, cleaning the case, all those instructions which we give you, if you follow, there is almost zero risk of any infections with the contact lenses. As far as spectacles are concerned, of course, there is no risk to wearing spectacles, even the special spectacles. As far as low dose atropine is concerned, a small percentage of patients will get photophobia or little difficulty in light because the pupil is a little dilated. But that is more in the Caucasian or the white skins with blue iris and green iris because that dilates. Our brown iris, dark iris dilates very little with the low dose atropine. So in my practice, I've been using it for the last 3-4 years now, low dose atropine. I've never had to stop treatment because of photophobia or glare that the patient experience. So they are almost free of all side effects, all these methods. Thank you.
Thank you so much, sir. Thank you for answering that question and the other questions for our viewers and for making them understand about the topic in such a better manner. I would also like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session. And I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with us, sir. Before ending, sir, any last take-home message from your end?
Yes, as I said, myopia control should not be left to the eye surgeons alone or to the opticians or to the optometrists. It has to be a teamwork in which I want the parents to take part. I want the family physicians to take part. I want the uncles, aunties, whoever is connected to the child. Children are too precious. And for the first time, we have some methods and measures to prevent control of myopia, to allow control of myopia. So we must all take part together in rescuing our children from this myopia pandemic. And I thank organizations like the IJCP to propagate this message far and wide. Thank you.
Thank you so much, sir. Thank you for your valuable message. With this, we would like to conclude the session here for today, and I would request everyone to take care of themselves and stay safe. Thank you so much, sir. Thank you.
Thank you.